Welcome all to this presentation sponsored by Dr. Data. Today we're going to focus on the gut cardiometabolic syndrome connection. And this is a really timely topic because of late we've seen an alarming increase in visceral adiposity, central adiposity, obesity in general, and due to current circumstances, we're going to see even more of this in the future. So it's very timely that we take care of this now, as opposed to waiting for crisis management. So just as an overview, today I'm going to just address adipose tissue with focus on the visceral adipose tissue, the VAT. Then we're going to talk about the central role of the gastrointestinal microbiota and inflammatory dysbiosis, and then tie it together with a look at cardiometabolic risk factor assessment, and of course, with interventions. So cardiometabolic syndrome really has evolved from a concept of syndrome X, dysmetabolic syndrome, to metabolic syndrome, and ultimately, appropriately, cardiometabolic syndrome. And all of this entails visceral adiposity, insulin resistance, diabetes, dyslipidemia, hypertension, and cardiovascular disease, as well as renal dysfunction. Entails chronic low-grade inflammation and ultimately fatty liver. So we've all seen from the epidemiological studies that the apple body shape, that is the abdominal or central adiposity, is at higher risk for cardiometabolic syndrome, cardiovascular disease, whereas the pear shape appeared to be much more protected. However, we see these body types, but what I see a lot more today is what I call the parapples, and that is where we just have both abdominal, central, and pear-shaped adiposity. So things aren't looking good. So we have a major underappreciated endocrine organ, that being adipose tissue, not just a sack of fat. Of course, it's loaded with triglycerides for energy stores, but it has some pretty cool hormones on it as a nucleus. And very importantly, it's a very dynamic endocrine organ, secreting a vast array and abundance of adipose cytokines, which constitute the adipo-cardiovascular crosstalk system. The problem, particularly in central or visceral fat, that is the VAT, we have a gross infiltration and activation of macrophages, which have metabolic consequences locally and systemically, and are fueled by lipopolysaccharides. When that happens, we lose that wonderful adipo-cardiovascular crosstalk. Now, visceral adiposity is problematic in that it directly releases fatty acids to key organs like the pancreas and the liver. But we have, again, this massive infiltration and occupation by these tumultuous macrophages and other immune cells. And this is particularly predominant in VAT, visceral adipose tissue. And what happens is these macrophages become resident. They secrete pro-inflammatory cytokines and reactive oxygen species, which disrupt adipokine metabolism, insulin resistance, and dyslipidemia, endothelial dysfunction, and low-grade systemic inflammation just by their presence. But we can throw gas on that fire. We can throw gas on that MAC-VAT fire in the form of endotoxemia, lipopolysaccharides. Now, I emphasize lipopolysaccharides are not inherently bad. They're, in fact, essential outer membrane constituents for all gram-negative bacteria in our gut. That's about 70% of our gut microbiota. But also importantly, the problem is when we have chronically elevated plasma LPS, as we do with cardiometabolic syndrome. So it's this chronic elevation. And that stimulates further recruitment and activation of macrophages into VAT, which exacerbates the release of pro-inflammatory cytokines and affects local and systemic inflammation with metabolic consequences. Now, LPS, we have to keep in mind, this is a sterile endotoxemia, so to speak. And for obese individuals, LPS levels are chronically elevated about half to 2 times higher than non-obese individuals. But keep in mind the term sterile in that even this level of elevated LPS is about 10 to 50 times lower than that seen during frank septicemia. Now, we have normal absorption of LPS from the gut. It's very abundant in the gut. And that is, we see a transient postprandial increase in LPS, circulating LPS with high-fat diets. That's because they're brought in just normally on the chylomicrons. But when we have abnormal paracellular breach of the endothelial barrier, we have a marked influx of LPS. And that is, of course, gastrointestinal permeability, paracellular, which can be measured by looking at serum zonulin family proteins or the lactulose mannitol test. So what we have is a setup for metabolic endotoxemia at the gut, and that's in the form of inflammatory dysbiosis. So we have all kinds of different dysbioses. We've come to appreciate that now. And in general, we're talking here about a very selective, diminished microbiota abundance and diversity associated with a gross imbalance. This inflammatory dysbiosis with increased permeability has been shown to be associated with obesity, diabetes, excessive gestational weight gain, and high-fat keto diets. I also see it with the severely restricted FODMAPs diets. So what is this? Well, we see a higher than normal abundance of the pro-inflammatory proteobacteria, Enterobacteriaceae, Shigella, and Escherichia. In contrast, we see diminished levels of F. prosnitzi, Eubacterium rectal, the Clostridium species, major butyrate producers, Bifidobacterium, Akkermansia mucinifera, and the butyrate-producing Lactospiraceae. So these are all associated with very low saccharolytic fermentation and most notably very low fecal butyrate, short-chain fatty acids. This is associated with compromised mucosal integrity, function, and metabolic disruption. So I really like pictures, and what we're looking at here is the mucosa under conditions of an abundant normal biosis with diversity and sufficient dietary prebiotics. So what we have is the propionate activating appropriately lymphocytes, but the propionate and butyrate activating the enteroendocrine L cells to secrete gut peptides, peptide YY, and glucagon-like peptide 1. These have a net effect on the body of decreasing postprandial glycemia and affecting a positive satiety and increasing energy expenditure. So speaking of energy expenditure, we also have butyrate and acetate working through PPAR gamma, activating beta oxidation, which not only creates energy, makes the enterocytes very happy, but also creates a markedly anaerobic microenvironment in close vicinity to the mucosa. We also have my favorite cells, the goblet cells, under the direction of butyrate and acetate, releasing massive quantities of mucins, which form that mucus barrier, about 5 liters a day, that wonderful barrier that constitutes the intestinal barrier system. So that's under normal circumstances. But what happens when we have this decreased abundance and diversity and or usually with inadequate prebiotics, including inadequate polyphenols? So we lose that propionate regulation of the lymphocytes. We lose that activation of and release of glucagon-like peptide 1. We also decrease the production of mucins and decrease that mucosal barrier system at the level of the mucus, which harbors the secretory IgA. And ultimately increase paracellular permeability, which result, and also, of course, that loss of oxidation, increasing the aerobic environment in close proximity to the mucosal barrier, which favors the Enterobacter ACI, the more pro-inflammatory bacteria. So the net effect is increased appetite, dysglycemia, permeability, metabolic endotoxemia, VAT max on fire, and inflammation. So let's switch gears now and talk a little bit about the actual patient in the context of what we're going to look at with respect to laboratory testing for risk factors for cardiometabolic syndrome. And I'm not going to cover all those, just the ones that I'm particularly fond of. We're talking about a 68-year-old female, sedentary female with a family history of coronary CVD. She's 5'5", 200 pounds, excessive abdominal fat, a very high BMI for what that's worth. She presented with fatigue, hypertension, shortness of breath, and type 2 diabetes mellitus was suspected before ordering the GI 360 stool test and the cardiometabolic panel. So first thing we're going to look at is the results of her stool analysis. And what we're looking at here is a nice diagram representing a hexagon representing the 6 primary bacterial phyla. And what we have is the patient's profile in this white web in the center. So this was all determined using a very highly focused dysbiosis test, which entails the use of 45 specific PCR targets covering an expanse of over 300 bacterial species. Then that patient's results are compared to a very large normal biotic reference population numbered at over 1,100 at this point. And then we plot the patient's results based on standard deviations away from normal biosis. And what you can see here is a significant pulling down higher levels of the proteobacteria, the Enterobacter ACI, Escherichia, and a shrinking in the Firmicutes department in particular. So as things pull away from this nice sweet spot, this green zone, which is 0 standard deviations from normal dysbiosis, we see a marked increase in these pro-inflammatory bacteria. Now, if we plug the patient's data into an algorithm, we can get a nice single-digit dysbiosis index. This, by the way, was approved by the European Union for a dysbiosis test by the Norwegian researchers. So this patient's profile pulled heavily down to the proteobacteria was associated with a very bad dysbiosis index of 5, 0 to 5 being the range, 3, 4, and 5 not being so good. When we look at the details of what the patient had, we can see the increase in the proteobacteria, Escherichia species, and then the significantly low, greater than two standard deviations or more low levels of the primary butyrate producers, which not surprisingly, when we go to further into the GI 360, we can see the short chain fatty acid status being very dismal and the butyrate levels being extremely low. So not a good situation, setting up for increased permeability and endotoxemia. So let's look at specific risk factors right now. The adipokines, look at leptin, adiponectin. Leptin, of course, has always been recognized as the satiety hormone because it signals the hypothalamus to suppress appetite and stimulate energy expenditure. But we actually see, which is a good thing, right? But we see increased leptin with obesity, endotoxemia, glucocorticoid drugs, alcohol abuse, hypothyroidism, and depression. And that's because what we have is leptin resistance. That excessive visceral adiposity leads to leptin resistance, and of course, an increase in the pro-inflammatory cytokines and oxidative stress. This is associated with decreased insulin secretion and increased hepatic fat accumulation, increased heart rate, and blood pressure. So it accelerates atherogenesis and is associated even with acute myocardial infarction and stroke. So in sharp contrast, when we look at adiponectin, we can see that it's just the opposite. We're talking about low levels of adiponectin in this situation. And adiponectin is very anti-inflammatory, antioxidative, anti-diabetic, vascular protective. It stimulates insulin release and sensitivity, increases fatty acid oxidation, and lowers hepatic triglyceride content and secretion, something I'm going to focus on. So we see low levels with cardiometabolic syndrome, obesity, hypoxia. Don't forget that obstructive sleep apnea, ischemic stroke, and even lung and other cancers, according to epidemiological studies. So adiponectin is good. We want it to be normal or even slightly on the high end of normal. But even more important than the individual adipokines is the ratio, a high ratio of leptin to adiponectin, the LAR, because that has greater sensitivity than either adipokine alone. It's an independent predictor of carotid intima media thickness, and a high LAR with elevated CRP, which we have in our patient here, it has even greater predictive value for a coronary artery disease. So we need to look at that leptin to adiponectin ratio. What's clinical intervention for a high LAR? Lifestyle changes, we're going to hear this a lot. Diet, physical activity, fresh fruits and vegetables, we need those bioflavonoids. Remediation of gastrointestinal dysbiosis and intestinal permeability. Intake of proanthocyanidins, grapeseed extract, aged garlic extract in double-blind placebo-controlled trials, balanced essential fatty acids, omega-6, omega-3. Metformin gets the job done, as does berberine. And remember, berberine also improves insulin sensitivity and increases LDL receptor expression, particularly on the liver. So next thing, what about hyperglycemic excursions? We talk about pre-diabetic, increased glucose, increased insulin, and even elevated hemoglobin A1C. But that doesn't get it all done, because we really need to look at the serum level of 1,5-N-hydroglucatol, which is a natural food-derived, non-metabolized glucose like polyol. It's at constant serum levels due to diet, due to appropriate renal resorption. But it's heavily competed for resorption by glucose. And so when we have hyperglycemic episodes, we see decreased levels of the 1,5-AG in serum. And so we see low 1,5-AG with the hyperglycemic episodes, that is greater than 180 milligram per deciliter. Importantly, over the past 1 to 2 weeks, not like hemoglobin A1C, which is an average over 2 to 3 months, and doesn't even pick up these episodes. Why are we talking about episodes? Because the episodes are more highly correlated with cardiovascular disease and diabetic complications, even in patients that maintain HbA1c levels of less than 7, okay, which is what we're told is a good thing. Now, look at markers of inflammation. We've got the phospholipase A2 activity, homocysteine grossly elevated, CRP elevated in the high risk range, and phospholipase A2 lipoprotein associated is associated with the progression of coronary artery disease, plaque instability, and risk of cardiovascular events. It's derived from macrophages, the enzyme, and it interacts with LDL and oxidized LDL, producing oxidized lysophospholipids and fatty acids that directly contribute to endothelial inflammation. Not a good thing. So if phospholipase A2 activity is high. We want to look at lifestyle factors, again, diet, exercise, weight reduction. We want to look at red blood cell fatty acid analysis. What's the DHA and EPA? We know that those can decrease phospholipase A2 activity. Check HDL, particularly HDL ApoA1. If low, assess CoQ10 levels, do a fat-soluble vitamin assay, and if low, supplement with CoQ10 and lower all other cardiometabolic risk factors. Now, when we look at the standard serum lipids and lipoproteins panel, we see a very common, for this patient, metabolic syndrome mixed dyslipidemia. We see elevated total cholesterol, LDL cholesterol, dismally low HDL cholesterol, and a significantly elevated plasma triglycerides, something that I will elaborate on. So let's take a greater look at the LDL culprits, a greater focus on the real LDL culprits. Just LDL cholesterol doesn't cut mustard. And importantly, these specific LDL subfractions are not, levels are not proportional to total LDL cholesterol. So when we look at oxidized cholesterol, we know it's a strong independent risk factor. It's involved in the initiation and progression of atherogenesis, associated with acute MIs, angina, hypothyroidism. So we need to consider lifestyle, trans fatty acid intake, smoking, toxicant exposures, oxidative stress, insufficient antioxidants. Okay, we're going to elaborate on that. So lipoproteins are inherently protected in an ideal situation by a host of antioxidants. Very exciting to me, a couple of years ago, a friend of mine was in on discovering that HDL and LDL circulate not only with glutathione, but with glutathione peroxidase, also tocopherols. Now, LDL is about 5 times higher in glutathione concentration or content. However, HDL carry paraoxidase 1, that is PON1, which, if you're interested in environmental medicine, has always been associated with hydrolysis of organophosphorus insecticides, but it also hydrolyzes lipid peroxides. So we have this paraoxidase 1 protecting the lipoproteins. So let's talk a little bit more about that, PON1. As related to cardiovascular disease, it's derived from the liver, and low PON1 activity is associated with increased risk of cardiovascular events, and that's because PON1 attenuates atherogenesis by being an antioxidant, protecting HDL and LDL, decreases oxidative status of macrophages in arterial lesions, stimulates cholesterol efflux from macrophages. So decreased levels we see with LPS endotoxemia, low HDL ApoA1. Berberine and quercetin increase PON1 gene expression, and polyphenols have been shown to increase PON1 activity in diabetic subjects. So the good old polyphenols, not only good prebiotics, but also jacking up PON1. Small dense LDL is another highly focused LDL atherogenic subspecies. It's a strong independent risk factor. Small dense LDL, as implied, is cholesterol ester depleted in the core, smaller, readily penetrates the endothelium, carries less glutathione tocopherols, and it's readily oxidized and taken up by macrophages. Small dense LDL is associated most commonly with elevated triglyceride levels and low HDL ApoA1. Intervention, exercise and weight reduction, niacin, fish oil, fibrates, and statins. But there is evidence that indicates that statins may increase the level of small dense LDL when a patient has normal levels of triglycerides. So this is something I've been fascinated in my entire research career, and that is the effect of the expanded triglyceride pool to remodel lipoproteins. So basically what we're talking about here is LDL start out as really are normally very cholesterol ester rich particles, but in the presence of an expanded triglyceride pool size and the activity of cholesterol ester transfer protein, the LDL become enriched with triglycerides. Those triglycerides are then cleared by hepatic lipase, and we end up with very small, dense LDL particles. Likewise, HDL is normally cholesterol ester rich, but with an expanded VLDL triglyceride pool size, donor pool size, increase cholesterol ester transfer protein activity, we see enrichment of HDL at the core with triglycerides. Again, with increased hepatic lipase activity, we see very small, dense HDL particles that are not very atherogenic. Now, when we look at the kinetic studies of stable radioisotopes labeled leucine, we see that in obese and metabolic syndrome patients that insulin resistance and hypoadiponectinemia are associated with increased VLDL triglyceride and ApoB production rate, decreased fractional catabolic rate, increased cholesterol ester transfer activity and hepatic lipase, as well as decreased lipoprotein lipase activity. Importantly, increased fractional catabolic rate of HDL, breaking down HDL, and lower ApoA1. So ApoA1, very important. We've always thought about ApoA1 being a key activating cofactor for lecithin cholesterol acetyltransferase, which esterifies free cholesterol, the cholesterol ester. But some really exciting new research published in 2019 indicates ApoA1 has important roles in cardiometabolic syndrome, and we need to keep those levels up. ApoA1 is secreted with nascent discoidal HDL particles from the liver associated with PON1. ApoA1 suppresses recruitment of monocytes into plaque. It increases insulin-dependent and insulin-independent glucose disposal and ameliorates inflammation. This has been shown both with the vasculature and during gestation, which is a pro-inflammatory state. So we do need to pay attention to that ApoA1, but we also need to look at total ApoB, which is the non-HDL particles, chylomicron remnants, we never hear anything about, intermediate density lipoproteins, the LDL culprits, and then the final LDL culprit, the LP little a, lipoprotein little a. Now, lipoprotein little a is a very genetically determined, the levels of which are very genetically determined. It's an independent risk factor for premature heart disease, thrombosis, and stroke. And lipoprotein little a is a funky little lipoprotein particle where we have a covalent bond between the ApoB of LDL and the Apo little a. And that turns out to be a structural antagonist for plasminogen and tissue plasminogen activator. It impedes fibrinolytic activity. So it's not only an antagonist, but it stimulates the secretion of tissue plasminogen activator inhibitor, as does leptin. Double whammy there. So there's no good interventions for lowering lipoprotein little a. It's slightly decreased by diet and exercise. In some individuals, we see marginal beneficial effects with fish oil and niacin. And what's really interesting is the LP little a itself, covalently bound to the ApoB, is loaded with sulfhydryl groups. And those sulfhydryl groups, there has actually a former colleague of mine got a use patent for using DMSA to lower LP little a. It's simply a use patent. He never demonstrated any efficacy, off-label use, so don't try this at home. But I think it's really interesting that people are looking at that. Again, there's no solid way to lower LP little a. There's a clinical trial going on with a nonsense fragment that can be injected, a biological that can block the transcription and expression production of lipoprotein little a. So my takeaways are the insidious effects of VAT are not remediated by simply donning the sweatpants or puffy pants. The gastrointestinal microbiota and associated metabolites have a central role in the initiation and progression of cardiometabolic disorders. The GI 360 readily identifies inflammatory dysbiosis and dysfunctional microbial gut community. And modern research-based laboratory testing provides metabolic biomarkers that have high predictive value for cardiometabolic syndrome, cardiovascular disease, early detection of metabolic disruption, and clinical intervention are paramount, and can be detection of these disruptions can be very motivating and can be used to monitor progress. We've got to get a hold of this now because it's not going to get any better unless we do. So thank you kindly for your attention.